Hi viewers, in this video we will discuss pulse deficit and S1 in atrial fibrillation. Let us review the physiology of pulse first. During diastole, left ventricle relaxes and receives blood from left atrium. The volume which is present at the end of the diastole is known as LV end diastolic volume. The normal end diastolic volume is 120 ml. This LV filling stretches the muscle fiber, which can increase the strength of LV contraction. During systole, it is because of the LV contraction, the LV pressure rises abruptly. When the left ventricular pressure is greater than the left atrial pressure, which is about 8 mm of mercury, mitral valve closes and produces first heart sound, that is S1. Further rise in left ventricular pressure opens the aorta and the LV ejects blood into the aorta. The normal stroke volume is 60 ml. When the left ventricular pressure is greater than the aortic pressure, which is 80 mm of mercury, aortic valve opens. So during LV systole, LV contraction begins, closes the mitral valve, opens the aortic valve and ejects its content into the aorta. This rise in LV pressure and stroke volume generates a pressure wave which is transmitted to the peripheral arteries felt as pulse. So it is because of this LV pressure and stroke volume which can create a pressure wave and transmitted to the peripheral arteries much faster than the blood column, which can be felt as pulse. Frank-Starling's law says that the force of LV contraction depends upon the length of muscle fiber at the end of diastole. In other words, if you increase the left ventricular end diastolic volume, the stroke volume also increases. So I can explain it in a better way. Increase in the left ventricular end diastolic volume leads to more stretching of muscle fibers, which can increase the force of LV contraction and leads to greater LV contraction, which increases the stroke volume. If the left ventricular end diastolic volume is low, the muscle stretch is very less, so the LV contraction is very weak and the stroke volume decreases. So what I am trying to say is LV end diastolic volume, otherwise known as preload, determines the stroke volume and the strength of pulse. Normally, every LV contraction produces a palpable peripheral pulse. With this, now we move on to atrial fibrillation. The major features of atrial fibrillation are: number 1, rapid ventricular rate; number 2, irregular LV contraction; and number 3, pulse deficit. In atrial fibrillation, the atrial rate is 350 to 500 per minute, whereas the ventricular rate is 110 to 160 per minute. Why there is a difference between the atrial rate and ventricular rate? It is mainly because of the high AV nodal refractory period and slow conduction nature of the AV node. If you increase the AV nodal refractory period by drugs, you can reduce the ventricular rate to below 100 per minute. And another important feature of atrial fibrillation is AV conducts the atrial impulses irregularly, which leads to irregular LV contraction. Now we move on to pulse deficit. In pulse deficit, the heart rate is greater than the pulse rate. Both heart rate and pulse rate are counted simultaneously for 1 minute. Heart rate is counted by auscultation of first heart sound, whereas pulse rate is counted by palpating the radial artery. In this example, you can see the heart rate is 124 per minute, whereas the pulse rate is 110 per minute. The difference between the heart rate and the pulse rate is 14. That is, the pulse deficit is 14. Normally, every LV contraction produces a palpable peripheral pulse, which means if the heart rate is 80 per minute, the pulse rate is also 80 per minute. Now the question is, why is there a pulse deficit in atrial fibrillation? Let us review the ECG features of AF first. The features are: number 1, absence of discrete P wave. This is mainly because of the absence of atrial contraction, presence of fibrillatory waves, varying RR interval, and the heart rate is around 100 to 160 per minute. So these are the features of atrial fibrillation. To know the pulse deficit, we need to know the following concept. In ECG, the QRS complex represents LV contraction. In other words, the QRS complex represents LV systole, whereas the RR interval represents ventricular relaxation and diastole, which means the RR interval indicates LV filling time. In AF, RR intervals are irregularly irregular. So ECG is a mixture of short and long RR interval. In this ECG, you can see here the RR interval is short, here also it is short, here the RR interval is prolonged as also here. So ECG shows varying RR intervals, short and prolonged RR intervals. The important point here is the RR interval determines the duration of diastole, which affects the LV endostolic volume and stroke volume. Let me explain this further. During long RR interval, the duration of diastole is prolonged, so the LV has sufficient time to receive blood from left atrium, and the LV endostolic volume is more. This leads to more stretching of muscle fiber and greater LV contraction. So the LV pressure and stroke volume are adequate to produce a pulse. What happens in short RR interval? In short RR interval, the duration of diastole is shortened, so the LV endostolic volume is low. This leads to poor LV contraction. So the LV pressure and stroke volume are too low to produce a pulse. Remember, during LV systole, mitral valve closes when the LV pressure is greater than 8 mm of mercury, whereas aortic valve opens when the LV pressure is greater than 80 mm of mercury. So this poor LV contraction can close the mitral valve but cannot open the aorta. This is the basic concept of pulse deficit. Now I can explain pulse deficit with an example. Counting heart rate by auscultation. Every LV contraction closes the mitral valve and produces S1. So for every LV systole, we can hear first heart sound. In this example, you can see the total number of S1 is 20, whereas the total number of pulse is 15, which means the pulse deficit is 5. As we already discussed, in this short RR interval, the stroke volume is too low to produce a pulse, but this LV contraction can close the mitral valve and can produce first heart sound. So this is the explanation for pulse deficit. So in atrial fibrillation, it is because of the short RR interval, the LV endostolic volume and stroke volume are too low to produce a pulse. So this is the explanation for pulse deficit. Now we move on to varying intensity of S1 in atrial fibrillation. The intensity of S1 depends upon the position of leaflets at the end of diastole. So in this picture, you can see the mitral leaflets are deep into the LV cavity. That leads to wide excursion of the leaflet and produces loud S1. In this picture, you can see the mitral leaflets are close to the mitral valve, which produces soft S1. So in atrial fibrillation, during short RR interval, this LV contraction occurs immediately after the previous one, which finds the leaflets deep into the LV cavity and produces loud S1. Whereas this LV contraction occurs in long RR interval. So during this time, the mitral leaflets move close to the mitral valve, which produces soft S1. So this is the explanation for varying intensity of S1 in atrial fibrillation. So in short RR interval, the intensity is loud. That means the S1 is loud. In long RR interval, the S1 is soft. Finally, we see the features of atrial fibrillation. Number 1, tachycardia. Number 2, irregular pulse. Number 3, the pulse deficit is more than 10. Number 4, absent A wave in JVP. because of the absence of atrial contraction. And the fifth point is varying intensity of S1. Please subscribe, like and share Dr. PK Medical Lectures. Thank you.